So I want to challenge you with a little bit about what I think the future can hold in medicine and where we need to go. And then I'm going to be curious what you think about it. So I called this item, this title kept changing, but today I decided I was going to call it Unlocking the Value of Healthcare Data, Secrets to a Better Future in Healthcare. Because I think fundamentally we're on the cusp of an amazing revolution in medicine, and it's going to be predicated on our ability to bring together the power of digital health data and put it to use for the benefit of patients and for the healthcare systems. So I say this, I start with this image because I'm telling you that despite all of our advances in medicine, we are in a knowledge drought. So we can pray for rain, but I think more than that, we've got to fix this problem. And I articulate it like this. I say that the current medical research enterprise cannot keep pace with the information needs of patients, clinicians, administrators, and policymakers. An example is this article that was published in one of our top journals that looked at the scientific evidence underlying the clinical practice guidelines. So our professional societies come together and they put together recommendations based on the evidence that exists to guide physicians in talking to patients about what works and what doesn't work. So in 16 current guidelines, looking at 2,711 recommendations, so you can see we have no shyness about making recommendations. Only 314 had grade A evidence associated with them. What that meant was strong studies that supported the recommendation. And it turned out about half of these recommendations were just based on expert opinion. This is a histogram that's showing you the breadth of performance. This is publicly reported by the government of the outcomes that are achieved in the treatment of patients with heart attacks. The numbers on the bottom actually should have been put in percentages. So 0.15 is 15%, 0.20 is 20%. What it means is where you get hospitalized has a lot to do with whether or not you're going to survive the hospitalization. And then there's this pressure about increasing cost. And this is comparing, many of you have seen this before. This is looking over the years from 1980. This went to 2012. How much money is being spent by different countries per capita on healthcare? The thing I find interesting about this whenever I look at it is I didn't realize when I first started studying this that in 1980, actually the countries were quite close to each other. Well, this is still, 15 years after Medicare comes into being, and the countries weren't so different, but since 1980, the separation has been profound. But if you look at the way cost of Medicaid around the country has been going, it's remarkable. And the other thing about it that's interesting is about a third of the states are spending about a third of their state budget now on Medicaid. So you start thinking about what that means in terms of not having money available for roads and schools and other things. I mean, and that doesn't count, by the way, that's not their whole healthcare spend. That's just on Medicaid. That doesn't count state employees or other things they're spending on either. So all of these things are creating a perfect storm. And I think the answer, so what is the answer going to be? I think it's about trying to be smarter about the way in which we're delivering care, smarter about ensuring that patients are most likely to benefit and aligning what's being done with what patients' preferences and goals are and be accountable for the performance. So I say what we want is for timely, personalized, humane, effective, and efficient care, we need informed decisions and smart caring systems. And medicine for a long time was a maverick activity. Individuals who were doing their best, fighting against disease, working on behalf of patients, doing relatively heroic work on all levels of the healthcare system. But there's also been a remarkable amount of waste and variation that's not been driven by patient need, but by what each person thinks is best. And it's time for us to begin to understand what that's producing and work together to make smarter decisions all the way around. I say that medicine is increasingly an information science that cares. And so that I say data generated every day for a variety of practical purposes could serve as an inexhaustible source of knowledge to fuel a learning healthcare system. So the way it's been working is there's been so much potential knowledge that's never been converted. It's the interactions between doctors and patients every day that is sort of left between that patient and their doctor. And other patients aren't able to benefit from whatever that person's experience was. So there was an Institute of Medicine report, and they said, ideally, each patient experience reflects the best evidence. That is, what we do every day reflects the best that we know today. And in turn, though, adds seamlessly to learning what works best in different circumstances. What this means is that we do our best job we can today, but we take advantage of all the data that's being generated from all the interactions that are occurring to help us make better decisions tomorrow for the person. And we're taking all the data that's available up until right now, and in real time, it's being converted so that the next person I talk to, I can take advantage of all the experiences. So I say there are 5 rules for unlocking medical value in data. And I'm just gonna go through what I think is the steps that we need to take to do this. So rule number 1, set data free. So we've got a situation right now where data is siloed. One of the problems is that we can't bring it together in a common place so that it can be useful in a way that we can actually learn from it. So the first thing we have to do is we have to say, it's like we have all this oil in the ground and we can never use it for fuel because we never even seek to pump it out. But not only that, we don't know how to refine it. We don't know how to prepare it. We don't know how to pull it together in ways that'll make it meaningful. So this has gotten the attention of the federal government too, because these electronic healthcare systems are almost designed to be siloed. And so the Obama administration report slams the digital health records. They say these electronic health record companies are blocking data. So this idea of it being blocked is a problem. And so it ends up siloing it. People have only parts of the data. They can't bring it together. So I like this picture where it's sort of like, 2 goldfish looking at each other, but they keep thinking they should be able to be together, but they just can't figure out any way to do it. This has to change. Data has to be unblocked. It needs to remain secure. We need to respect people's privacy, but we need to be able to bring data together in ways that we can learn from it. I think we need to set data free securely for patients. One dream I have, the team here knows about it now. Let's empower the patients, give them the data. Let's create a way in which they can now move it and feel empowered and engaged. I believe this is really possible today. And I also believe it's possible once you do that to work with patients to combine data and make them participants in the learning. What I don't like is when we go around patients. Let's get health systems combining data. Don't tell the patients. They don't need to know. We'll de-identify. By the way, I don't know that there is such thing as full de-identification anymore. I think make the patients partners in this effort. Enlist them as data donors. Tell them what you learn. Make them feel part of the team. Change the dynamic. It's not like, oh, they don't know. They don't want to know. They're out there. I think you can change the way we talk to communities and individuals, and we can make them part of this. So the second, and these others are faster, don't worry. Keep the data computable and analyzable. This is an inside baseball point, but I'm just going to show you how crazy it is in medicine. We take data that's structured and can be analyzed, and then you ask for it, and we actually go backwards and give you a form of the data that you can't do much with. We lose information that way. We go from rich information that can be linked and analyzed to something that's not. So I say basic tense, if it's structured, keep it structured. That means if it's tagged and organized in ways that it could be analyzed in a statistical program or used to inform you in ways, keep it that way. If it's not structured, at least keep it analyzable in the real text. Never make it less understandable. Help data move when it's needed. We need to be able to create ways for people to securely, safely, privately move data to where they want it to be moved. So this goes along with my idea that's saying, if you're going somewhere and you need to be able to move it, make it so that it can move. Make it so we can bring it together. With patients' permission, this will fit. We need the whole picture. If we're getting only part of the picture, we won't learn anything. We need it where and when we need it. Every piece of information helps. When we're trying to figure out what people's experience is with disease, when we're trying to learn how the next person ought to be treated, when we're trying to create new hypotheses and make new discoveries. It also means we need to collect more data in ways that are meaningful. So I did want to say something because Jack mentioned this post-hospital syndrome I've talked about. So one of the ways we can help is by collecting information that's meaningful and will help us improve and also help patients to track certain aspects of their recovery. So in this post-hospital syndrome, I say, we take patients in the hospital and we disrupt their sleep. We expose them to loud noises and bright lights, painful stimuli, uncomfortable environments, food and water restriction. You know, actually, there was a study that said 50% of the patients are getting only 50% of the nutritional needs. And when you're sick, by the way, you need more nutrition. And then we limit their mobility. But imagine in the hospital if we said every patient, a vital sign now is gonna be how much did they sleep at night? How much activity did they have? We're gonna monitor their nutrition, so you'll actually see calorie counts. We'll be able to see what the noise level was in their room at night. We're gonna see how many times they were woken up. You know, all of a sudden we're gonna start tracking this stuff and it becomes part of something we can follow. It becomes part of their record and it becomes part of something we may realize that we need to address if we're gonna create more humane environments. It's data used to promote the humanity in medicine, not to extract humanity from medicine. So whenever I talk about digital health and data, it's in the service of being more humane, smarter, better able to respond. I was saying when you start collecting data too, this positive deviance method that we put together was basically, you can start plotting performance and then look at the end of the tail and say, what in the heck are those people doing? How are they excelling? What did they do that was so good? And how can we learn and generalize from it? But if you don't have all this data, you can't begin to do it. This is the thing I was saying about organizational culture. I think we should start to be able to measure organizational culture. I think you guys know already there are ways to do that. I've been saying this burnout phenomenon among physicians is actually a major impediment to providing high quality care. Again, how are we measuring that within our organizations? Our organization's health is a critical component of our ability to execute our strategies and serve our communities. 4 is embrace complexity. This is one of my favorite ones. In medicine, for some reason, the researchers have opted to become very reductionist in the way they look at patients. So what I try to do as a researcher, I was taught, simplify the problem as much as possible so that you can study one single thing in great depth. The problem is, this is a biological map of a patient with genomic information and everything. The problem is people are complex. If I really reduce everything so I can do good statistical testing and narrow down on one little thing, then it doesn't teach me what I need to know about a patient who comes in with 15 different problems on 20 different medications, or even the person who's only got 2 problems and 3 medications, but is complicated. But look what we do in medicine. We've got this calculation we make. It was this CHAD score, which then we improve with a CHADS VAS score. And what we did was, I swear, this is state of the art. We took a bunch of what we call risk factors for stroke. So heart failure, hypertension, diabetes, vascular disease, age, whether you're a woman, and whether you had a previous stroke. And we assigned numbers to them, and we said, add them up. And, you know, so they create these algorithms. Okay, I can go down. If you're older and a woman, you should definitely have a high enough risk to be anticoagulated. It's nuts. We're all carrying computers on our belts. We should be using 100 variables. Everything about you I can learn. It should be funneling into an advanced analytic program, and it should be telling me what your likely risk is based on it. Now, in cancer care, they're looking at molecular signatures now to start with. It's no longer organ-specific. They're using molecular signatures to try to begin to describe cancer. It's as if we're just being given a microscope. And now we're going to see the world in very different ways, because if we can have access to the data, we'll be able to see it like that. And so the final thing is about this, we need to also then, once we can learn how to collect the data, bring it together, now we're analyzing it in really sophisticated ways that, by the way, have yet to be done, but we're going to start doing. Then the final is, how does it go into action to make a difference in people's lives? And that's going to be about how we communicate the information meaningfully, how it's actionable, how it's helpful. We got to be held accountable for that, because it's not just that we're doing all this work with the data. It has to help people live longer and better. It has to help decisions be better for individuals. So I say good information is rendered useless unless it's communicated well. And I'll go through this quickly, but I mean, I think for an example, What's a patient-centered informed consent? Are we really helping people make informed choices? Are we delivering the information in ways that people can understand? So even before we get to these advanced analytics, we've got to figure out, how do we communicate clearly, fairly, accurately? And it'll allow our decision-making to be driven by patient preference, not by our framing of, no, I saw you got a blockage and you need to get this procedure. I think all of these consents, then if we build this information in the background, start to lay out options for people, talk about the benefits and risks, the costs, and the performance of the team that we're proposing do this. So that you know everything about what's available to you. You know that reasonable people may make different choices. You're not being forced down a path. Two people can make the same choice and both be right if it fits their preferences. And so we feed now this information from a growing, learning healthcare system into easily understood terms, and we make sure that it covers the waterfront about what people need to know. The right timing, the right content, the right presentation, the information, and the understanding. So I just go back to this. For timely, personalized, humane, effective care, we're going to need informed decisions and smart caring systems, and I believe that the way to get there is going to be to really harness the data, the fuel, the information that we can harvest from everyday practice. And I just think it's all about us reimagining what tomorrow's going to be in medicine, putting patients in a stronger position, getting them as participants in this process, and making a commitment to make medicine advance in ways that we haven't yet seen. And I'm optimistic about the future of it if we can do that. Thank you.